If you take a small pill every morning for your blood pressure, but you still feel exhausted, your waistline keeps growing, and even climbing a single flight of stairs leaves you short of breath, then what I'm about to tell you may shock you. Because there's a real possibility that the very medication meant to help you could actually be working against you. And the most surprising part, millions of people are taking it while having no idea what it may be doing behind the scenes. I'm Dr. Berg, and on this channel, we break down the latest health research into simple, practical information, especially for adults over 60 who want real answers, not outdated advice. If you're not subscribed yet, do that now. Because today's video might completely change the way you think about your blood pressure medication. We need to talk about beta blockers. You may know them by names like Metoprolol, Lopressor, or Tenormin, or by their generic names like Metoprolol and Atenolol. For decades, these drugs were considered one of the standard treatments for high blood pressure. Doctors prescribed them by the millions every year. They were familiar, inexpensive, and trusted. But here's the problem. Medicine moved forward. The research changed, the evidence changed, but for many people, the prescription never did. And now, for many older adults with uncomplicated high blood pressure, beta blockers may no longer be the best option. In fact, in some cases, they may be quietly making several things worse at the same time. Let me explain. Your heart has tiny receptors on it. Think of them like locks. Adrenaline is the key that fits into those locks. When it connects, your heart beats faster and harder. That's part of your body's natural response system. Beta blockers step in and block those locks, so adrenaline can't do its job the way it normally would. As a result, your heart rate slows down, your heart pumps with less force, and your blood pressure drops. On the surface, that sounds like a good thing, and in some situations, it absolutely is. If someone is recovering from a heart attack, if they have heart failure, or certain dangerous heart rhythm problems, beta blockers can be life-saving. That is not what we're questioning here. But if a person is taking a beta blocker only for basic high blood pressure, and especially if they're older and otherwise stable, then the story becomes very different. And this is where things start to get uncomfortable. Because one of the biggest turning points came from a major study called the ASCOT trial, the Anglo-Scandinavian Cardiac Outcomes Trial. This trial followed more than 19,000 patients with high blood pressure. Researchers compared one group taking a beta blocker plus a diuretic with another group taking a calcium channel blocker plus an ACE inhibitor. And then something happened that got everyone's attention. The trial was stopped early. Why? Because the results were already too clear to ignore. The patients taking the beta blocker combination had more strokes, more heart attacks, and more new cases of diabetes. Meanwhile, the other group had 23% fewer major cardiovascular events. 23%. That is not a tiny difference. That is the kind of number that forces the medical world to reconsider what it thought it knew. And that's exactly what happened. After that study, and others that confirmed the same pattern, the UK's health authority, NICE, removed beta blockers from their recommended first-line treatment for uncomplicated hypertension. But even now, millions of people are still taking them as their primary blood pressure medication, often simply because the prescription was written years ago and no one ever went back to question it. Now here's where this gets personal, because the issue isn't just what the medication does to your blood pressure reading, it's what it may be doing to your energy, your metabolism, your quality of life, and your future health. The first major issue is fatigue and exercise intolerance. This matters far more than most people realize. When beta blockers limit your heart's ability to respond to activity, they also limit how much your heart rate can rise when your body needs more oxygen and more circulation. For a younger person sitting behind a desk all day, maybe that effect isn't obvious. But for a 65-year-old trying to stay active, for a 70-year-old who wants to walk every evening, for someone who wants to play with their grandchildren, go shopping, garden, or simply move through life without feeling drained, that limitation can be devastating. You get winded sooner, your legs feel heavier, you tire out faster, and exercise starts to feel much harder than it should. That creates a vicious cycle. The medication makes movement harder. Less movement means worse fitness. Worse fitness makes blood pressure harder to control naturally. And before long, people start blaming their age when it may not be their age at all. It may be the drug. And that's only the beginning. The second major concern is metabolic damage. This part is rarely explained clearly to patients, but it matters. Beta blockers have been linked to increased insulin resistance, higher triglycerides, and lower HDL, the good cholesterol. In other words, the medication may help lower one number on your blood pressure cuff, while quietly pushing other important health markers in the wrong direction. And for older adults already dealing with weight gain, rising blood sugar, or prediabetes, that is a serious concern. Because now the question becomes, what good is a medication that makes the blood pressure reading look better if underneath the surface it may be contributing to fatigue, reduced activity, metabolic decline, and a higher risk of diabetes? That's not a small trade-off. And here's what makes it even more troubling. Many patients see a reading like 128/78 and assume everything is fine. But numbers don't always tell the full story. A person can have a good blood pressure reading and still feel tired all day, still gain weight around the middle, still struggle with worsening blood sugar, and still slowly lose the ability to stay active. So yes, the reading may improve, but what is the real cost? And then there is a third issue, one that is especially dangerous in older adults: fall risk. Beta blockers can sometimes cause orthostatic hypotension, which means your blood pressure drops suddenly when you stand up from sitting or lying down, that brief dizzy spell when you get out of a chair, that lightheaded feeling when you stand too fast. For a younger person, that may seem minor, but for a senior, it can be the beginning of something much more serious. One fall, one fracture, one hip injury, and life can change overnight. That is why this conversation matters so much. But before we go any further, I need to make something crystal clear. Never stop a beta blocker abruptly on your own. That can be dangerous. Stopping suddenly can trigger a rebound effect, causing your heart rate and blood pressure to spike rapidly. In some cases, that can lead to chest pain, arrhythmias, or even a heart attack. So this video is not telling you to throw your medication away. This is about giving you the right information so you can have the right conversation with your doctor. Now, the obvious question is this: if beta blockers may not be the best first choice for many seniors with uncomplicated high blood pressure, then what does the research support instead? Two classes of medication stand out. The first is calcium channel blockers. A common example is amlodipine. This class performed better in major studies like ASCOT. It does not carry the same level of metabolic concerns seen with traditional beta blockers, and it generally doesn't limit exercise capacity in the same way. For many older adults, that can make a meaningful difference not only in blood pressure control, but in how they actually feel from day to day. The second major option is ACE inhibitors and ARBs. These include medications like lisinopril, ramipril, losartan, and olmesartan. These drugs have shown consistent benefits in many patients, especially those with diabetes risk, kidney concerns, or the need for broader cardiovascular protection. Now, ACE inhibitors can cause a persistent dry cough in some people. If that happens, doctors often switch to an ARB, which works through a similar pathway, but usually without the cough. So what should you do with all of this? First, look at your current medication list. Ask yourself, am I taking a beta blocker specifically for blood pressure only, not because of a previous heart attack, not because of heart failure, not because of atrial fibrillation or another arrhythmia, but simply for hypertension? If the answer is yes, then the next step is not panic. The next step is preparation. Before your next appointment, write down these three questions. First, was my beta blocker prescribed specifically for hypertension, and does that still reflect current evidence-based treatment recommendations for someone like me? Second, have we checked my fasting glucose, insulin, triglycerides, and overall metabolic health recently? Third, based on my complete health picture, would I be a candidate for a calcium channel blocker, an ACE inhibitor, or an ARB instead? These are smart questions, reasonable questions, necessary questions. And if you've been on the same medication for years without any serious review, ask for a full medication reassessment, because many people are still taking treatments based on old habits in medicine. not current evidence. If your doctor believes a change makes sense, then ask how the transition would be done safely. A responsible taper usually happens gradually over several weeks, sometimes 4 to 8 weeks or longer depending on the person. And while that process is happening, start tracking your symptoms. Keep a simple daily log, your morning blood pressure, your energy level from 1 to 10, your blood sugar if you monitor it, and any dizziness, fatigue, or exercise intolerance you notice. That kind of real-world information can make your appointment far more productive. Now, one important clarification before we finish. There are absolutely people who should be on beta blockers. If you have coronary artery disease, a history of heart attack, heart failure, or certain rhythm conditions, beta blockers may still be the right and important treatment. It is saying that for older adults whose only issue is uncomplicated high blood pressure, the evidence suggests it may be time to revisit whether this is still the best choice. And that is a conversation worth having. Because if your medication is leaving you drained, if your weight is creeping up, if your blood sugar is moving in the wrong direction, if you feel weaker, slower, and more limited than you used to, you deserve to ask why. And you deserve a treatment plan based on what the evidence says today, not what was standard 20 years ago. So if this sounds like you, bring it up at your next appointment. Don't ignore the fatigue. Don't dismiss the weight gain. Don't assume it's just aging. Sometimes the real problem is hiding in plain sight. Inside the very pill you've been told is helping you. I'm Dr. Eric Berg. If you found this video helpful, subscribe to the channel and share it with someone who needs to hear it.